Hi, I'm Dr. Joseph Witt-Doering. It is my pleasure to be joined by Jaden Brandt here. He is a PharmD, he's a clinical psychiatrist and also a clinical teacher at the Rady Faculty of Health Sciences at the University of Manitoba. He's also on the scientific advisory board for the Alliance for Benzodiazepine Best Practices, providing scientific oversight there for what the advocacy work they're doing towards informed consent for benzodiazepine use and deprescribing. And it's just a delight to have him here. I'm going to be talking to him about standard of care in benzodiazepine deprescribing because he's actively doing research in that area. And so I hope you enjoy the conversation. Jaden, welcome again. And so why don't you just start off by telling us, how did you get interested in benzodiazepine deprescribing and protracted withdrawal injury and things like that?
Yeah, I'm happy to. So just to also very briefly set the record straight for the audience, I'm not yet a PharmD. I'm doing my doctorate of pharmacy through the University of Alberta, but I am a licensed pharmacist in Manitoba, Canada for the last 10 years. And I do have a Master of Science in benzodiazepine pharmacoepidemiology. Essentially, my story as a healthcare provider began in 2013 when I graduated out of the University of Manitoba. I went up north in the province of Manitoba to my hometown and started trying to really apply the clinical instruction that I learned in school over 4 years. And I became quite discouraged noticing a lot of that the trends, particularly in psychotropic medication use, was very much in deviating from best practices of what we learned about in school, and particularly with benzodiazepines in the patient population that I was seeing. This was a patient population that was frequently of lower socioeconomic status, had various social issues. There were a lot of disparities in northern health region. And I saw that these people weren't necessarily getting the best quality of care, particularly when it comes to their mental health. I saw a lot of overprescribing and excessive use of benzodiazepines, dose increases that were very difficult for me as a young and initiating kind of pharmacist to justify. I worked effectively with some prescribers, not so effectively with others, and I think I had a fairly positive impact on the patient population that I served.
Just to sort of spell it out, were you seeing people, rather than getting benzos for a month or two, usually they're meant to be used, they just weren't being reviewed, they just kept on?
We're talking many years of benzo use, duplicate benzodiazepines with zopiclone. We're talking opioids in conjunction with benzodiazepines and dose increases as well. So it really ran the gamut. I saw quite a lot of problematic use, even benzodiazepines being initiated and then renewed for anxiety disorders and things when we're taught, as with many psychiatrists or mental health professionals that are prescribers, that we would typically see an antidepressant being used as first line. Now those drugs obviously come with their own issues as well, but there were a lot of just deviations and difficult to justify prescriptions. So I worked effectively and would mitigate as much harm as I could, working with both patients and prescribers. But it really spoke to the issue of how deep is this problem? How widespread is it? I'm practicing in Thompson, Manitoba, but is this a province-wide issue? So it got me delving a little bit deeper into the literature, but it also prompted me to want to explore this from a population health science perspective. So I came back and did my master's degree between 2016 and 2019 with a diploma in population health concurrently, so that I had a little bit more of an understanding about health policy, knowledge translation, other issues surrounding health promotion, chronic disease state management. And it really, basically, my findings were not necessarily as shocking as I thought, but still a concern. There were a lot of factors that were prevalent that did show room for improvement, and we often see these in pharmacoepidemiologic studies on benzodiazepines where there is room for improvement. So one of the most interesting things that I noticed was over a 15-year period, there was a 300% increase in zopiclone or Z drug use. compared to other benzodiazepines. In the early 2000s in Manitoba, we typically saw a much more diverse array of benzodiazepines being used. Alprazolam, clonazepam, diazepam, bromazepam, pretty much everything. And then over time...
Let me ask you this.
Sure.
Do you think that was because those Z drugs, they're newer drugs and they were marketed as being safer, and so there was a transfer over onto those? I mean, how do you understand a 300% increase in those?
I think that's an excellent question. So I think for one, the practice change in insomnia management, really in having newer prescribers and older prescribers adapting to this this belief that Z drugs are obviously a safer alternative to benzodiazepines. So that was part of it. I also speculate, and this is perhaps an ecological fallacy, and it would need to be studied a little bit more, but I think that just generally speaking in the Western world, with the increased use of mobile phones, technologies, electronic devices, having an impact on our sleep function. And then that may be also driving increased insomnia prescriptions overall, whether we're talking Z drugs or other agents. Now, predominantly I looked at the benzodiazepines and benzodiazepine receptor agonists, so I couldn't confirm whether we would have seen increased rates of, say, prescriptions for off-label trazodone or doxepin or mirtazapine, some of these other agents. But I think that without kind of speaking outside of my scope of expertise, I think that a lot of variations in our modern lifestyles have disrupted sleep patterns, and that could have led to some of these changes over a 15-year period. So that was one of the biggest findings, was that pretty substantial increase. The other was that benzodiazepine use beyond the Z drugs, like the classical or traditional benzodiazepines, their use over time really became consolidated into about 4 agents. We saw increases in the use of clonazepam, and then there was still considerable use of diazepam, alprazolam, and lorazepam, of course. So those were kind of the top 4. But other agents that you don't often really think of or see very much of, chlordiazepoxide, chlorazepate, or temazepam, their use did decrease. And that would make sense, especially with temazepam being more often used for sleep anyway, being replaced with zopiclone. Now, this study was on drug utilization. It didn't necessarily look at harms associated with these things, but looking at the broader literature and how well established a lot of the harms already are, when we're talking motor vehicle accidents, psychomotor impairment leading to falls or fractures, things of that nature, I think that you don't always necessarily have to follow things through to the full conclusion. And then gradually, I think science can kind of lead the way to making fairly general inferences based on what we already know from these drugs.
Mm-hmm. Okay, so it sounds like you caught the bug then, and I mean, you finished that epidemiology diploma or study, and then you kept on going.
Yeah.
How did you end up picking up deprescribing guidelines? Where did you? Because this has been a massive multi-year long project for you to look at the deprescribing guidelines. Tell me about how you got started on that.
Sure. So in order to kind of effectively speak to that, I think I should probably talk about my history with starting with the Alliance for Benzodiazepine Best Practices, because that's essentially where this comes together. After I had completed my master's and I was in practice for a few years, really working with the patient population that I was seeing in Winnipeg, and successfully tapering patients off of benzodiazepines that were willing to, and who I was convinced that there was some ongoing harm or loss of their quality of life, I encountered this not-for-profit group online, run by Bernie Silvernail. So I reached out to him because I thought, this is right up my alley. This is an area that I've done some research in already. We made contact, and this was a number of years ago now, probably about 3 or 4 at least. And it was the medical director at the time. It was really his baby, his idea, Dr. Stephen Wright. he had compiled a core evidence package and had very thoroughly examined and collated a number of clinical practice guidelines that covered both prescribing and deprescribing. Now, my thought was, this is excellent. Why don't we? But in order for the world to kind of effectively know a lot of what we've discovered, we need to put this through more of a rigorous methodology. We need to, in order to do an effective knowledge synthesis on this, we need to do something like a scoping review. So that's currently what this is. I can't really speak necessarily to the results at this stage because they are preliminary and we're in the latter phases of the project. It is also challenging to do a large project like this and spearhead it as a PI when you're a part-time student and a practicing pharmacist and all the other things that life, of course, throws at you. But it's been a very worthwhile journey, and it's certainly not something that can be done solo. But generally speaking, in engaging with a lot of these documents and collecting them, running them through an inclusion-exclusion criteria and determining basically the international collection of guidelines for both prescribing benzodiazepines and anxiety and insomnia, and even for depression that's presenting with anxiety. And then also examining deprescribing guidelines more focused for any particular condition where long-term use is no longer indicated and we need to try to taper patients off.
Let me ask you specifically about deprescribing, because as I mentioned previously, I often get called upon to do forensic work for benzodiazepine injuries, and usually it's for protracted withdrawal injury. And so what we do is, excuse me, sorry about that. I'm going to start over. So I do a lot of, so as I mentioned before, I do a lot of forensic work for people who've been harmed by benzodiazepines, especially protracted withdrawal. And one of the, at least anecdotally, one of the most high-risk periods for developing this is during a rapid benzodiazepine detox. And this is something that commonly happens in detox clinics all around the US. I mean, I'm talking people get pulled off in, less than a month, sometimes even sooner. They might be on high doses and they just kind of rapidly pull them off over the course of several weeks and they throw them on gabapentin. Some people come out of this with severe injury that lasts for years. And so from my perspective, I always want to know is, who said that was a reasonable thing to do? Was this the American Society for Addiction Medicine? Maybe because a lot of addiction doctors are the ones overseeing those practices. And I never really knew the answer as to why it was okay to do that to people rather than a gradual patient-led taper. So I was wondering if you could kind of speak to that and just sort of just tell us, what do you see in those guidelines out there? Who's the most authoritative group out there? And what do they say?
Sure. So there are a number of guidelines that cover deprescribing. There's some from the National Institute for Healthcare Excellence, I think, out of the UK. I don't know if I got that acronym right. It has changed at some point in the past 10 years or so. They have a quite authoritative guideline that covers psychotropics generally. So there is guidance on benzodiazepines in there. There's also the guideline from the deprescribing.org or Deprescribing Network that is a Canadian collaborative. Those guidelines are quite well cited and fairly well established as being of high rigor and standard. They use the GRADE criteria, which is become a gold standard for evaluating evidence and making recommendations. A lot of these guidelines, however, what I will say is that they often don't explicitly engage their audience with how to effectively engage with shared decision making for patients. They often prescribe a kind of generic deprescribing approach that is, I would say, probably fairly effective for some, but not necessarily all patients. So I think that, as with anything, and I think we learn this in clinical medicine, that guidelines are not always going to be definitive in every situation, or they can be authoritative, but ultimately they're guidelines, they're guidance. We need to really adapt them to the purposes of the individual patient that we're dealing with and treating. I think when we're talking about deprescribing, one of the most critical things to always bear in mind is, whenever possible, really put the patient at the forefront and empower them to engage in the deprescribing. So an analogy I've previously used in an interview, a medicating normal interview, but I also think that it's quite useful to illustrate it for patients, is that, as an expert on benzodiazepines, or for anybody who's an expert on antidepressants or other psychoactive medications that require tapering, unless there's maybe a high-risk scenario where we need to taper them off sooner, or an inpatient setting or something of that nature, I like to imagine that the patient is in the driver's seat, but it's almost like one of those training vehicles where you have your foot on an emergency brake pedal, and the patient can kind of drive it at the rate that they're comfortable. But if they're going too fast or deviating off the road, you, as the driving instructor, in this case the deprescribing facilitator, can always put on the brakes or make an adjustment if needed. So one thing I will say more kind of generally, and this is working from memory of the deprescribing guidelines this is the deprescribing benzodiazepine receptor agonists guidelines out of Canada, the deprescribing.org guidelines, published in Canadian Family Physician Journal. They generally offer a fairly, I think, robust tapering plan. They don't necessarily advise switching to a long-term benzodiazepine, which I is actually in opposition to some of my approaches and strategies. I find that I will often, especially when you get near the end of a taper, switching a patient to like a gold reference standard, diazepam in particular, is particularly useful. And so there is, I would say, fairly minimal acknowledgement or advocating of like the Ashton method, which, to some extent is evidence-based in and of itself and is highly respected. But there's many ways of tapering. So I also think that the guidelines out of Canada are a really great place to start, and I'm not just saying that because I'm Canadian. I think that they have set an early gold standard, but there does need to be more work in establishing deprescribing guidelines in the U.S., say for especially like from a large national organization.
So what do they say, just in general, like the deprescribing Canada guidance? What, if you were to kind of just explain it in a minute or two, what's the general philosophy in there?
So the general philosophy, I believe, is to typically taper kind of at a rate of 10 to 25% reductions, maybe every 2 to 4 weeks or something of that nature. I'm working off of memory here. And then once they get usually down to the 25% of their original dose, they will potentially go lower and go slower. But oftentimes the intent is a tapering regimen that will discontinue somebody from a benzodiazepine definitely in less than a year, sometimes within 3 to 6 months, or potentially sooner if they're on a low dose enough already.
I mean, if they're doing 25% every 2 weeks,
yeah,
I mean, that's like 2 months, they could be off.
It's significant, and it's not something that I necessarily believe with the patients that I've worked with is relatively feasible. I also think that we need to account for the possibility of those plateaus where a patient reaches a certain dose, and based on what is happening in their life at any given moment, various stressors and other factors, they might want to hold that taper for a considerable duration, and I think that as long as there is kind of ongoing risk assessments and monitoring in place, I would say that is appropriate, and that's something that can be encouraged and will also strengthen the patient-provider relationship.
Let me ask you this: what do you make of the contrast between the deprescribing.org guideline and I guess what is actually commonly used out there in the deprescribing circles, where they'll say maybe 5% a month, sometimes even slower, with tapers going, because that sounds like what you're doing. Like how do you or something more slower and more flexible, like where does that difference, how come there's that divergence that you have all these people with the lived experience doing it one way, but then deprescribing.org is essentially saying we could get you off in like 2 to 3 months, no worries?
Yeah, I think that's an excellent question. So if I were to speculate on kind of squaring the circle in terms of how that came about, I would say that oftentimes with guidelines, they do a fairly rigorous search and a kind of systematic review process of the evidence. And I would say that common practices aren't necessarily captured in the evidence, especially there have been a lot of kind of variable approaches to tapering, and there has never really been a gold standard. So when they work with what is available in the literature, what they come up with could very well be justifiable, but it isn't necessarily the optimum approach. I think that given enough time and studies that are maybe conducted and captured using real-world evidence in real patients, guidelines 10 years from now could very well look a lot like what you and I might be doing.
And I guess here's another question, and I don't know if you've gotten to this kind of level of resolution with the study. It's a lot of like it may their advice to have people stop over 2 months, that might be fine if someone's been in a clinical trial, like a controlled clinical trial for 3 months or something like that. And I know at least in the antidepressant world, that's where a lot of the discontinuation guidelines have come from. They've been add-on studies on the backside of clinical trials that have just been short duration, in the months. And so that almost makes it look like it's a lot easier to come off the medications. But the reality is that the patients in those studies, they've only been on the drugs for like 3 months, as opposed to maybe what you and me see in the real world, where it's like, we got people who have been on them for a decade. And so, I wonder if that's a possibility as well, why the guidelines become so skewed, because they're based on an unrepresentative patient population from a short-term clinical trial rather than like real patients. I mean, is that what you're seeing when you're looking at the references of these guidelines?
I would say that's a very perceptive observation to make. I would say that it's frequently like that in clinical trials for really any kind of disease state, when there's going to be inclusion-exclusion criteria, or we're looking for a positive effect, or we're trying to limit confounding factors. A lot of these multi-morbid, complex patients are going to be unfortunately excluded. But they're very much included in real life. And as you and I know, the guidelines don't necessarily are applicable or relevant in all cases to help some of these individuals. So I do think that with enough time, and especially in light of more patient engagement in research, if you look at some of the research that has come out from our colleagues in the Alliance, looking at benzodiazepine-induced neurological dysfunction and things of that nature, I think there will be a stronger case perhaps over time to really engage in a slower, more patient-oriented deprescribing approach broadly to kind of limit these benzodiazepine injuries and neurological dysfunctions. Does that kind of answer your question?
It does. I just don't know when that's going to happen. I do know that the FDA, in conjunction with, I think it's the American Academy of Addiction Medicine, is currently doing one of these things. And I mean, if that comes out and it's good, it will be one of the most authoritative documents, at least in the US, to
Absolutely.
have something like that. And so I'm kind of waiting in bated breath to see whether it looks good or not. I mean, I am a little bit weary. I know that the contributors are, heavily stacked in academic settings where, I mean, they're more like career academics rather than people who actually treat folks with benzodiazepine withdrawal. And so I suspect they're just going to be influenced by the same, I guess, I don't know, the same kind of chorus that you see in the medical literature, and which people have kind of heard again and again in practice, like, oh, it's not that bad, it's over in a couple months, and anything other than that is just scaring people. So
Yeah.
I'm kind of, trying to not get my hopes up too much. Yeah.
No, that's very true, and I think that there is a real risk of that happening, especially when it is predominantly academic clinicians that are engaged in this. And it's not to say that these folks aren't highly intelligent and capable as researchers, but if they're not necessarily engaging actively and highly actively in treating hundreds of patients that are requiring kind of gradual dose reductions and drug discontinuation, that personal expertise that you develop in working with these individuals isn't necessarily reflected in what we see in the guidelines.
There's something about the fact that all over the country there's people getting hurt in these detox centers by addiction medicine docs, and the guideline is being driven by the addiction medicine group, where I'm just like, well, if you're letting that happen, I mean, are you going to come out with a guideline saying, this is wrong? What's happening? I mean, I hope they do. It's just, I wonder if they have that, if they're going to be able to see past it, because I'm frequently told it's missed. I mean, it is. They eventually they just go, okay, you have another psychiatric condition. See you later. And it's like,
Sure.
Thank you for your $30,000.
Yeah, and it's unfortunate when we talk about drug-induced harm, especially for psychotropics, where there could very well be kind of an established stigma that develops or encapsulates a patient's life when they're written off as having somatic syndromes or other issues associated with the harm of psychotropic medications. So I think really ensuring that also individuals like you and I that are actively in practice, when we encounter some of these more unusual or bizarre situations where there could very well be, say, a benzodiazepine-induced protracted withdrawal, where tinnitus or some other kind of physiologic adverse effect phenomena is more prevalent, that we actually file a report if we think that this is happening to our, in my case, Health Canada, and yours maybe the FDA, so that these things actually do come to light through real-world evidence more actively. I think a lot of it exists on patient forums or these kind of recovery support networks for patients, and I think that's positive. But that isn't necessarily strong enough to create the change within the systems of healthcare provision.
In your scoping review, do you cover the Ashton method?
I don't recall if we do or don't. There's over 100 guidelines in there. I would think that if we did, we would remember. But the Ashton method is well established and well regarded, but based on the methodology that we employ, it wouldn't probably suffice as a guideline per se. It might suffice as a guidance document, but if it's by one prominent and well reputable British psychiatrist, it doesn't make for a consensus-based guideline. So it could be due to methodological limitations like that it might be included. I'll have to check, but I will say that a lot of the slow kind of tapering that we practice isn't reflected often in the deprescribing guidelines at large. One of the major limitations that isn't in there as of right now is some of these more, I guess, kind of unusual or ad hoc methods of tapering that are not based on solid dosage form reductions. So we're talking about water dilutions or tablet shaving, things like that. And patients do this, and they could very well have some success. It's not something that I've done a lot of research on myself or looked into. I think the practice is perhaps more prominent in the US, and some of our colleagues at the Alliance can probably speak more readily about this than I am. But the very fact that it's happening and that patients are engaging in some of these more atypical tapering strategies means that I would think that they should be at least commented on in guidelines so that we know how to address them with patients and ensure that it's at least an option that people are doing.
Have you seen any guidelines at all while you've been doing this that reflect the kind of the patient experience that we see in our work, or is it all mostly just like deprescribing.org, you know?
I would say it's mostly like that, and deprescribing.org is one of the good ones. Like, don't get me wrong, there's a lot more guidance than your average provider would get on deprescribing otherwise without them. A lot of the other documents that I've looked at, because we examine both factors relating to the initiating and prescribing for one of the included conditions, so both initiation, maintenance, and then deprescribing. So we look at all three of those, and the documents that cover them are quite different. So occasionally you will see deprescribing or at least a suggestion of tapering in an anxiety disorder guideline or something like that, but it doesn't get into the finer granular detail of how to do that. It might just say as a one-off, say hypothetically in say the British Association of Psychopharmacology guideline, it might just say use for upwards or a maximum of 4 weeks and then consider tapering your patient off, but it won't necessarily say how. So that kind of, those things left unsaid are more filled in by the newer deprescribing guidelines. So I think there has been a huge paradigm shift with moving towards deprescribing within the last probably 10 years by and large.
Would you say that the NICE guidelines are probably the best? Because they're the only ones I've seen where they even acknowledge liquid titration for lower dose reductions. I don't know if there's any other guideline that goes into that level of depth.
Yeah, I haven't seen anything like that. There was one guideline, and I, if this work does at some point get published, it'll show up in there, but it was talking about making reductions on diazepam, reducing it by 500 micrograms or something of that nature. Now, you can't really do that in the current, so it's kind of left to the provider to think like, well, how am I going to do that unless I go a compounded route or I advise my patient to, I guess quarter tablets of 2 milligrams or something. But nonetheless, some of these things are left very much implied but not explicated on in enough detail to guide clinicians or patients on the strategy. But your observation of the NICE guideline is I think quite prudent. The NICE guidelines are probably some of the best that I've seen in terms of really empowering more shared decision making around patient discontinuation. There's a lot of variance within the guidelines currently, I think. So the purpose of a review like this is to kind of lay the groundwork so that future researchers or guideline developers on deprescribing can kind of see what already exists, why there might be discrepancies between guidelines, and then really look at consolidating the evidence maybe more thoroughly or properly, and then filling in the gaps where guidelines are otherwise silent. So that's what I hope that our research group can accomplish. But a lot of the conversation around this is preliminary because these results are still being processed and are in work and not yet submitted for publication either.
What were you taught about deprescribing when you went through your training?
That's a good question. Probably very little. I think deprescribing really came to the forefront.
I mean, did you have like one lecture, or is it just something you maybe heard from someone while you're out doing clinical practice?
Yeah, I think it was probably something more along those lines. If anything, we encountered the word tapering far more commonly than deprescribing when I was going through my undergraduate pharmacy training. So I would say that the terminology has shifted with this paradigm shift towards really focusing on finding and striking the right balance between patients' medication regimens. And I think at this point in time, there is far more of a curricular focus on deprescribing. I can say quite clearly that the dean of my pharmacy school, Dr. Lolitha Raman-Wilms, is associated with the Deprescribing Network, or the Canadian Deprescribing Network, and she and other colleagues have been very active at reforming curriculum for pharmacy students and other professions that are involved in prescribing, such as medicine and psychiatry.
Who's that
really
that's doing that? Sorry? Who's...
Yeah, so this is her name is Dr. Lolitha Raman-Wilms. You can also look up Dr. Barbara Farrell. Basically, it's people from the Canadian Deprescribing Network, but they've also collaborated with individuals internationally. Like there are probably over the last, I'm going to say the last 10 years, and that's kind of a landmark for me because that's when I graduated from pharmacy school and did not encounter much on deprescribing. But since then, it's really become a center kind of focal point, I would say, within pharmacy education, at least as I seem to interpret it. Not actually being in the classroom, but engaging with pharmacy students. They are far more aware than they maybe used to be. So, but in terms of the training, I think that the approach is to really assess people's medication regimens in a very systematic way, whether it's through some kind of framework like the indication, effectiveness, safety, and adherence framework, or the ICEA framework, or some other. But we're simultaneously looking for omissions of medications that patients might require to improve their health, and also looking at ones that are long past overdue for possible deprescribing opportunities. So the principles around it, I think, are kind of the same, but whereas maybe 20 years ago, people weren't really thinking about deprescribing at all. They were just thinking about prescribing, right? And now the focus has really shifted, and I think that's a very positive thing.
I don't know if you know much about the history, but how did these things get going? Was there sometimes, like, I know there's like a pivotal event, I think thalidomide for like drug regulation. Was there something that happened that spouted the growth of these deprescribing movements? I don't know if you know.
No, that's an excellent question. I would be curious to know the answer myself. I'm not aware per se. I think and again, it's more speculative, but I think it's the gradual acknowledgement that within the West, we often have an aging population with increasing medication burdens. And the medication lists seem to be growing among our patients over time and each and every year. And I think it kind of gets to that critical mass, and it's not necessarily an isolated major milestone event that triggered the deprescribing focus. And I could be wrong, maybe there was one. But my perspective is it's been a gradual realization that this is a problem. And then it took a recognition of that and a team of collaborative researchers to really take action and really start establishing best practices around this.
That's great. Well, Jaden, I'm about out of questions for now. Is there anything else that you wanted to share before we wrap?
No, I don't think so. But I do want to say I really appreciate the opportunity to chat with you. I think we're of similar mind when it comes to medication safety. I've appreciated your content and what you put out there to support people both suffering from psychotropic drug reactions as well as informing the public generally about these various issues. So thank you.
Thanks very much. I look forward to chatting with you
Likewise.
again soon.
All right. Have a great day, Joseph.